So today we are talking about child abuse, and the rationale for this is that child abuse is common, okay, yet under-recognized and under-reported. So when you start reading for Canadian exam and you see things like this is common, this is common, this is common, you want to start paying attention because that means that it's something you cannot miss so far as your exam is concerned. The reason is because if it's a common thing, why should you miss it as a doctor, right? So child abuse is common, yet under-recognized and under-reported. Timely recognition and evaluation of suspected child abuse is critical, allowing for early intervention to optimize outcomes for children and their families. All right. So the causal conditions. So when you're reading the objectives, you realize that every objective will have causal conditions, and they'll write that the list is not exhaustive. So physical abuse, sexual abuse, emotional and mental abuse, neglect, and exposure to domestic violence. All right. Now, then they have this key objective. We call it a key objective. It says that the candidate should be aware. So when you're learning about child abuse, by the time you are done, make sure that you've really recognized. It says that the candidate should be aware of presentations in which a history of abuse should be considered. So if I were you and I'm learning child abuse, first thing I want to ask myself is, under what circumstance will I start thinking about the fact that this child who has been brought in to my emergency room or to my clinic is being abused? So he says, given a child in whom a history of abuse is suspected, the candidate will construct an appropriate management plan with particular attention to issues of safety and prevention. So when you are learning child abuse, one other thing you have to pay attention to is management, escape plan, right? Should I report or should I not report? Given a child in whom a history of abuse is disclosed, the candidate will identify the cause, the severity, the complications, and contributing factors. An appropriate initial management and prevention plan should also be constructed. So you realize that they talked about treatment and appropriate management plan here. They are talking about it here as well. And it's all in the MCC objectives. I'm just quoting from the MCC objective. So I'm taking you now into child abuse itself. So I want somebody to read this question for me, please. I want a volunteer to read this question for me. So just mention your name. Let me know where you are joining us from, and then go ahead and read the question for us, please.
I'm Dr. Sarangi from Sri Lanka.
Sure, doctors. Oh, Sri Lanka. I've had quite a number of people who have gone to MedCognito who have done very well through Sri Lanka. Awesome. Like Dr. Mangala. I think Dr. Mangala.
Okay.
Yeah, sure. But it's okay. Let's read for us.
Okay. You are in the ER working and noted a child with her caregiver. You suspect abuse. What are the forms of abuse you are concerned about?
Exactly. Please type your answer. Don't shout it. Just type your answer. What are the forms of abuse you're concerned about in a child? What are the forms of abuse? Dr. Nandini, beautiful. I like that. Physical, sexual, emotional, psychological, non-accidental trauma. Well, non-accidental trauma is basically another name for abuse, right? So non-accidental trauma is not a form of abuse. Non-accidental trauma is basically abuse, right? Okay. So Dr. Wally says fracture. But Dr. Wally, we say the forms. We'll come to the issue of fracture, but the question was asking the forms. So Dr. Freddy says physical abuse and emotional abuse, physical abuse, sexual abuse, neglect. Beautiful. I like that one. Neglect. Very, very important. Neglect. Physical. Beautiful. Emotional. Okay, good. So it looks like we are getting it. So physical abuse, sexual abuse, psychological abuse, neglect, all these are forms of abuse or types of child abuse. Okay, so I will write it down. Types of child abuse. These are the things I'm going to focus on. Types of child abuse, types of child abuse, types of child abuse. So physical abuse, sexual abuse, psychological abuse, and neglect. Physical, sexual, psychological, and neglect. All right, good. Now, I want someone else to read this question. It's very similar, but then it changes because of the way the objective puts it.
Dr. Patrick.
So, Dr. Patrick, let's go. Thank you very much for reading.
No problem. You are in the ER working and noted a child with their caregiver. You suspect abuse. What are the risk factors are you concerned about? 2 caregiver risk factors, 2 child risk factors.
Sure. So please just type your answers. What are the caregiver risk factors you want to know? What are the child risk factors you want to know in a child with abuse? What are the caregiver risk factors you want to know? What are the child risk factors you want to know? So, Dr. Nandini, your answers, are they for child or for caregiver? So I'll suggest that if you are listing, maybe just write child and then list your answers. Okay, Dr. Nandini says her answers are for caregiver. So Dr. Samiran says parental situation. Dr. Samiran, in the exam, you want to be very specific, right? What is it with the parental situation? Because the parental situation can be good parental situation, right? It can be good. So what is it about the parental situation? Okay, so Dr. Nandini is saying for child prematurity. Dr. Samira says divorce. Dr. Nandini says disability, special needs. So Dr. Nandini, what I'll suggest is maybe in your board exam, if you write disability, don't add special needs, right? If you write special needs, don't add disability. Caregiver, Dr. Fejiro says alcoholism, divorce, substance abuse. Beautiful, beautiful. Okay, Dr. Azad says history of abuse. History of abuse in the caregiver. Because the caregiver is somebody who has been used to abuse. And they also likely abuse the kid. Okay. Dr. Freddy says caregiver alcoholism, financial and child congenital abnormality, and learning disability. Yeah, because at times it's difficult for the caregivers to handle these children. Out of frustration, they may then do some form of harm to the kid. Okay, sure. So let's go. So, and this is something I want you to take note. This way I wrote my answers is wrong. Don't do it this way. So let me maybe unshare my screen and then show you what I mean by that. So if it is environmental risk factors, make sure one answer per line. Okay, one answer per line. I just did this so that you will understand what I'm talking about. One answer per line. Please, in the exam, one answer per line. Caregiver risk factors, one answer per line. So psychiatric illness like psychosis, postpartum depression. So you can have a mother, just delivered a wonderful bouncing baby boy or girl, and then the mother does harm to the baby because of single parent family, poor social and vocational skills, below average intelligence, so low IQ. So I just use this as an example so you will see some of the mistakes people make. You may write social isolation and poverty on the same line, even though both of them are correct. But because you wrote it on the same line, you're going to get just one answer right. Right? So please make sure that you put one answer per line. One answer per line. That's why I just intentionally did this, so that I can use it as a teaching point. So what are the caregiver risk factors? Personal history of abuse, psychiatric illness in the caregiver, postpartum depression, substance abuse in the caregiver. And you realize that substance abuse is a whole MCC objective as well. Substance abuse itself. We have substance abuse disorder, substance use withdrawal. These are two objectives you need to also master. Okay. Then single parent family, and then poor social and vocational skills, and then below average intelligence. And when it comes to a child with a difficult temperament, a child with disability, okay, I'll say disability and special needs, premature child as well. So I think Dr. Nandini wrote prematurity. So these are also risk factors in the child, which will predispose the child to abuse. Doctors, please, are we all on the same page? And can I move on to the next one? So we've learned the types of abuse. We are learning the risk factors, and we learned that there are environmental risk factors, there are caregiver risk factors, and there are child risk factors for abuse. Okay.
But you get it well, very well.
Okay, so let me move on then. I want somebody to read this question for us.
You are in the ER working and noted a child with her caregiver. You suspect child neglect. How will a child with neglect present? List 3.
Beautiful. How will a child with neglect present? How will a child with neglect present? How will a child with neglect present to the ER? Because we've talked about abuse and we learned that neglect is one of the forms of abuse. But specifically, when it gets to neglect, how will a child with neglect, how will the history be like?
They're restrained.
What do you
They're
say?
restricted. They're restrained. They're restricted.
The child is restricted, sure. I've seen Dr.
Yes.
Wally says bruising, Dr. Kana
No
says
eye contact.
eye.
The child may look malnourished.
They look malnourished. Beautiful, beautiful, beautiful. Poorly dressed, poor eye contact, shy, no eye contact. So may look not normal, timid and withdrawn, trauma in unusual parts. Okay, so how do you identify that this child, or if I have a question stem, how will I be able to identify that this child is presenting with neglect? If that child failure to thrive, and there's no underlying medical reason why that child should be failing to thrive, that should raise a concern. Developmental delays, inadequate clothing. So maybe this is a child, it's winter, and the child is brought to the ER and dressed like they are in the summer. Well, you know that every parent who is very conscious and very cautious about their children will want to make sure the child is covered well. But when it comes to a child with neglect, you realize that maybe the clothing is inappropriate. So, this is not full-blown, the typical pathophysiology medicine that we do for acute kidney disease, heart failure and the rest. This looks like a social component of medicine. And this is where at times some of us also go very wrong. So I want you to really pay attention to this. Dirty clothing, poor hygiene, poor attachment to parents. So that's what Dr. Umar was talking about. That, this child does not want to even get attached to the parents at all. No stranger anxiety. So you are expecting that this child, at the particular age they start experiencing stranger anxiety. But this child would rather want to go to a stranger. Why? Because that child does not feel loved in the house or in the home he or she is coming from. So I have a question. At what age do children start experiencing stranger anxiety? Because
6 months.
There's a whole objective on, developmental issues. So when does a child start developing stranger anxiety? When?
I think it's 12 months, isn't it?
So someone says
Separation.
12 months, someone says 6 months. Who else says something different? When does it start? So it's about 8 to 9 months, right? They're about 8 to 9 months.
Yeah.
So if you have an 8 to 9 month old kid who in the emergency room with unusual history, and instead of clinging to the dad or to the mom or to the caregiver, rather wants to go to every other person, and you have other concerns, then it should let you start thinking, maybe is there a problem here? Right? So these are the things you want to pick up. Okay. So we've learned neglect, we've learned about the types of abuse, we've learned about I think we've learned about something else, but you are in the ER working and noted a child with her caregiver. You suspect child neglect. What historical features would you inquire about? I think we've already talked about it, but sorry, this is not child neglect alone. We are talking about this case should be about child abuse, not child neglect alone, abuse. So let me correct it. Okay, so let's go. So what are the things you suspect on a child, like a history from a caregiver that will start causing you to say, this case, I think it's a case of abuse. I have to look closer. What are some of the things you want to look out for, please? What are some of the things you want to look out for?
Malnourishment.
What do you say?
Malnourished. Maybe he's not eating properly.
No, but we are talking about history.
History. Okay.
Is something you pick up on physical exam, right? But history.
Okay.
What are you going to pick about on history How will the history be presented that you go like, this thing, I think it's abuse going on here. Delay presentation, beautiful. Scars, fractures. Is she afraid of people? Family support. Some people are saying single parent, alcoholic parent, caregiver claiming child is clumsy. So it's like the caregiver is trying to, give other reasons. So number one, history of injury is inconsistent with the developmental state. For example, you have a 3-month-old baby who has developed a femur fracture. Come on, 3-month-old babies don't walk. 3-month-old babies don't run. Why does your 3-month-old baby have a femur fracture? And these femur fractures are not easy to come by. That means whatever force was applied to cause that femur fracture was heavy. And then if there's a child who can speak, you realize that there's a discrepancy between the child's history and the caregiver's history. As soon as you start seeing that, you go like, okay, what's going on here? What's going on here? There's a problem. And then if the caregiver is given the story, maybe the changing of the story over time. Oh, and the child was playing at the playground. Oh, doctor, I forgot. It was rather in the winter. Oh, and then the child were cooking. The caregiver keeps changing the story. Keeps changing the story. Keeps changing the story. That should cause you to think there's something fishy going on here. Then delay in presentation, I think somebody already said it, without reasonable explanation. So you realize that a child with an obvious arm deformity, then a caregiver waits to come with 3 days later. Come on, who does that? Right? It is because maybe the caregiver is trying to cover up something, substance abuse or intoxicated caregiver. So the caregiver who brought a kid herself is smelling all of alcohol. They are concerned. Then lack of parental consent or appreciation of the significance of the injury. So maybe you have a child who is so hurt, but these caregivers, they don't look so concerned. And history of previous trauma or repeated visits. So you have somebody a kid who has been brought to the ER several times. Then you are concerned, like several times with, oh, he did this. He fell from the waterfall. He fell from the Niagara Falls. He did this. Then you realize that there's something I need to start paying attention to. And then history of domestic violence in other family members. So, for example, you have a kid whose maybe mother has been abused by maybe the partner, and then this kid is brought to the emergency room, and this kid now has, features that you're concerned about. Please be careful about that. So how will a child with abuse present historically? These are some of the things you want to look out for. All right? Doctors, is that clear? Is that clear? Okay, good. So you are in the ER working and noted a child with her caregiver. You suspect child neglect or child abuse. What physical exam features will point you to abuse in the child? You remember? No, so at times you pick the kids, abuse, this is abuse, I finished abuse. No. Don't do that. Abuse is very, very important. Then you realize that they even broke it down into 3: child abuse, elderly abuse, and intimate partner violence, right? So please make sure that you've clicked everything you need to click so far as this particular objective is concerned. So in the ER, working and noted a child with her caregiver, you suspect child neglect. What physical exam features will point to abuse in the child? What are the physical exam features that are, this is abuse, this is abuse, this case smells of abuse? So bruises, fractures, right? Altered mental status, retinal hemorrhages should cause you to start thinking, no, this child is going through hell. Patchy hair loss. Why patchy hair loss? Can somebody tell me why? Why patchy hair loss? Why is patchy hair loss one of the, one of the presentations of physical exam so far as child abuse is concerned? Patchy hair loss. Who can tell me why? Why patchy hair loss?
Maybe because
has taken from their hair or has.
So the child's hair is pulled, right? pulled.
Pulled by someone.
And then frenular tears, frenulum, okay? And then head trauma. And then we also have what we call metaphyseal corner or bucket handle fractures. So if you see something we call bucket handle fracture, that means there was a pull on that limb, either on the leg, right? So if you see this kind of fracture, it is almost always abuse. Bucket handle. So this is the distal part of the femur, and this is the patella, right? And this is the fibula. And if you start seeing this, it's like the child was pulled, and that is what is causing the problem. So, and then
Even sometimes nurse made a fracture is gonna be or no?
what do you say? What do you say? Sorry.
Nurse made a fracture. Nurse made fractures going also the fine.
We don't really call it nurse-made fracture. We call it nurse-made elbow. Nurse-made elbow is subluxation, okay? And usually that is not abuse per se. That is common. Because at times maybe the kid, you are playing with a kid, you even hold a hand and you pull, right? You are playing with a kid. The kid can develop a nurse-made elbow. So that is not typically of fractures. And then these metaphyseal bucket handle fractures, usually they occur on the femur, the humerus, and the tibia. And it is you're looking at a shaking MOI is mechanism of injury. So if the child was shaking, so they can even develop shaking baby syndrome, right? Or metaphyseal corner or bucket handle fractures. That's what happens in a child who is shaking very well. Okay, sure. And you can also see other fractures like fractures on the skull, fractures on the mandible, fractures on the vertebrae, fractures on the ribs, fractures on the sternum. When a child developed a fracture of the sternum, was there a blow to the chest, right? Fracture of the scapula. Look at where the scapula is. It is hidden under huge muscles, but then that can happen. Multiple fractures. And then fractures in different stages of healing. So it could be that this if you see fractures of different stages of healing, what should that tell you? Is it like an acute abuse, or the abuse has been going on for some time? What do you think? You have a child with fractures at different stages of healing. What should that tell you? Doctor, what should that tell you? Fractures at different stages of healing. What should that tell
Child
you?
abuse.
Child
abuse.
Abuse.
It should tell you that abuse has been going on for some time, right? To the extent that the child has been abused, some of the fractures are already healing, and there's new fractures. Okay. So this is what I was talking about, shaking baby syndrome, and this is what also causes the bucket handle fractures. So if you shake them, right, as you are shaking them, the leg is moving. That's why I'm saying that if you see bucket handle fracture, it is almost always as a result of abuse. Bucket handle fracture. Okay. So now, we've talked about, I want somebody to summarize. I want someone to summarize before we move on.
Mira,
Someone
acá
summarize.
me saca $306 y están cobrando acá,
Pero más tax.
pero mira acá,
Hello, please
acá está
kindly mute yourselves, okay? I
ahí
want somebody to summarize everything we've done so far.
y por $100 más, mira dónde está ella.
Hello, please. I think somebody is speaking. Dr. Gerardo, please kindly mute yourself, okay? I want to summarize what we've studied so far.
We learned child abuse, we learned child neglecting.
Child abuse, child
Yeah,
neglect.
which we learned risk factors for the child abuse, and we learned the history, physical examination, how we just figure out the physical examination that there's going to be like fractures, there's going to be like bruises, and we learned how we should take a history from the child abuse. The history is going to be different, and the history or the time of the history or is going to be different, and more is the history from the child and from the nurse caregiver or caregiver gonna be different. And we learned one more. Just this much I just summarized.
Sure, that's good. So now I'm looking at other characteristics of bruises that may be suspicious of non-accidental injury. Non-accidental injury means, abuse, right? So the anatomic location, if you see a child with bruises on the ears, subconjunctival hemorrhage, bruises in the mouth, intraoral, on the neck, in the inner arm, like in areas where you are not expecting injuries, on the thigh, in the anogenital region. So, for example, I have a question. You are in the emergency room. You notice a 6-year-old girl is brought in, and you notice genital warts. What's your next best thing?
We have to just investigate.
Investigate how?
It should not be the sexual abuse, because in this age it's not gonna be worse.
Sure. So if you see genital warts in a kid, what is your next step? You should report to Child Protection Services.
Immediately.
Yeah, you report to Child Protection Services. And don't forget that, when you suspect abuse in a child and you report, and then Child Protection Services does their investigations and there's no abuse, nobody's going to hold anything against you. So far as you do not do it out of malice, you are fine. Okay. If you suspect it, you report it. So if they also have injuries to the back, you report. If you have suspected bruise shapes like handprints on the child's back, that means an adult hits the child, right? If you see object marks on the child, bite shape, ligature bruises, okay? Multiple bruises. Bruises at different stages of healing. So the bruises at the different stages of healing are similar to bruises or fractures at different stages of healing. Dr. Nandani, please ask your question.
Are we supposed to take the history of abuse from the traumatized child? Is that recommended?
You can do that. You can do that. You can do that. You can do that because that can help you to even get a better view of what is happening, right? Okay. So we've talked about the patterns, multiple bruises at different stages of healing. And then bruises that may be concerning for child abuse, bite marks, right? Immersion burns. So at times some caregivers can be so wicked that I don't know what a kid has done. Then they'll just put the hand. So you realize that the child has gotten scald burns to maybe the arm or both, or maybe the feet, And then you're also thinking about head injury like bongs. So that's what we were talking about, hemotympanic. So one thing you want to use as an acronym is the B's, bites, burns, bongs, breaks, blues, right? Belt and buccal. So the B's, if I were you, I'll just write them down. The B's. So bites, burns, bongs. So bongs is like, head bongs. And when the head bongs, in retinal hemorrhages, bleeding behind the tympanum, fractures and breaks, especially in very young children who probably should not be having that kind of fracture. And then baby blues. So the child is so irritable, they can't even interact with their caregiver. Ligature marks and buccal, like in the mouth. So if in child abuse, if you remember the B's, if you even learn 4 or 5, you should be good. Now, if you see a spiral fracture, a child with a spiral fracture in the femur or the radius, think about abuse, because to develop a spiral fracture, the mechanism of injury should be very, very, very high. Like it should be a high mechanism, right? And spiral fractures are usually secondary to twisting mechanism of the injury. Twisting. So if you see spiral fractures in a kid, think about possible abuse in the kid. And then we're talking about reporting. Because remember that in the objective, we're supposed to deal with that. So in a case of suspected or actual child abuse, the physician is obliged, please, it's an obligation to report to the Child Protection Services. In a case of suspected or actual child abuse, the physician is obliged to the Child Protection Services. So you need to report that case. And one other thing you have to learn is that head trauma is the leading cause of death in child abuse and child maltreatment. So if I ask you an MCQ and I give, oh, a child is brought to the ER with suspected abuse, which of them is the leading cause of death? Head trauma, hand trauma, leg trauma, abdominal trauma. The answer is head trauma. Head trauma is the leading cause of death in child maltreatment and child abuse.